University can help us. Thank you. Thank you. Okay, so I want to take this moment to thank you for joining us for this important seminar, where we will be comparing findings from 2 cost-effectiveness modeling studies on HPV vaccination in Senegal and Tunisia. Before we begin, just a few housekeeping points. Today's session will run for 1 hour, 45 minutes for the main presentation, followed by 15 minutes. Sorry? And 15 minutes of Q&A. Please keep your videos off and microphone muted unless speaking. And feel free to use the chat to share comments or questions throughout the session. Our speaker today is Dr. OUMAIMA LARAJ, a postdoctoral research fellow at the Institute Pasteur in Tunis and a key member of the Africa Modeling and Analytics Academy in Tunisia. She is also a member of the Laboratory of Nonlinear Analysis, Modeling and Support for Decision-Making at Mohammed V University in Morocco. During the session, Dr. OUMAIMA will compare findings from 2 cost-effectiveness modeling studies on HPV vaccination in Senegal and Tunisia. She will highlight contextual differences, modeling approaches, and key insights for decision makers in both countries. The session aims to foster a better understanding of how modeling can inform vaccination policy, especially in low and middle income settings with distinct implementation challenges. Without further ado, I'll now hand over to Dr. OUMAIMA LARAJ to take us through the presentation. Dr. OUMAIMA, over to you.
Hello, good afternoon, everyone. Can you hear me?
Loud and clear. Go ahead.
Okay. Okay. I will start to share my screen.
This thing, I sit with it in the boardroom. Yeah. It's a meeting in the middle of July, I know that place is.
Peter Mutuma, could you please mute?
Many people don't know. It's so
Peter Mutuma, please. Thank you. Thank you. Go on, OUMAIMA.
Good afternoon, everyone. I will thank you all for joining today's meeting. I'm really happy to be part of the invited speakers for Africa seminar series, and it's a pleasure to present the results of our recent work on cost effectiveness of HPV vaccination in 2 different settings, Tunisia and Senegal. Cervical cancer is among the leading causes of cancer-related deaths among women, especially in low and middle-income countries. HPV vaccination is a powerful tool to prevent this disease, and that's why cost effectiveness. However, for the countries with limited economic settings, it's always about the cost effectiveness of HPV vaccination programs. So that's why the cost effectiveness is a crucial tool to help decision makers and policy makers to by providing both health impact and economic outcomes associated to the strategies. So before diving into the details, I would like to express my gratitude to all the collaborators and institutions who supported this work. So I will present an overview of what we will cover on this presentation. We'll first start by having an overview of HPV, the linking with cervical cancer and the importance of vaccination. Then I will highlight the role of mathematical modeling in decision making before presenting the key results and the main results of the 2 case studies in Tunisia and Senegal. And I would like also to present like a cross-country comparison to highlight the key differences and similarities between the two settings before drawing conclusions and key lessons from finally from our analysis. So HPV stands for human papillomavirus, which is a sexual transmittable infection. Many individuals infected with HPV may not experience any symptoms and may not even be aware of their infection. But it's important to have an idea about how do you get HPV. So as I have said, after your sexual activity, then you will if you get infected by one or multiple types of HPV, which are over 100 types. And in general, there is like two main classifications of HPV types or HPV genotypes. There are high-risk ones and low-risk ones, depending on if there is a possibility to develop a cancer or cervical cancer or other related cancers in the long term. So if you get infected by high-risk HPV types, there is like 70% probability, or you will have cervical cancer, you will develop cervical cancer or other related cancers. In 30% of cases, you develop the cervical cancer in the most of cases. And if you have been infected by low-risk HPV types, in 90% of cases, you will develop genital warts, or if it's low risk, there is a probability that your body clears the infection by itself. So the younger you are, the faster it cleans up. In general, HPV causes different types of cancer, not only cervical cancer. You can have vulva cancer, penile cancer, genital warts, as I have said, anal cancer, etc. But why it's important to focus on cervical cancer? First, because it's a women cancer. Then it's like causing like the leading cause of almost all cancer related women cancer. So like it's a cancer which can be preventable, and it's a cancer which is leading to a huge number of deaths among the world, women cancer deaths. In general, as I have said before, if your body can clear the infection by itself, but if it's not, you can develop in the first step, as we call abnormal cells or genital warts in your cervix. Then, if the treatment or the screening had not been there, or had not diagnosed your genital warts, it will be developed to cervical cancer in the long term. So that's why, what are the measures of prevention or control to eliminate this disease? As aligning with the whole global strategy, there is like 3 key points we can focus on for preventing such a disease. First of all, the HPV vaccination to prevent the HPV infection. Then the screen of cervical cancer screen to like diagnostic by chance if the woman have genital wart, in order like to treat it in this stage before developing to cervical cancer. And if it's diagnosed and confirmed cervical cancer, we need to make efforts for make effective treatment. So the whole global strategy is suggesting that 90% of girls need to be vaccinated between ages 9 to 14 years old. 70% of women screened with between ages 35 and 45, and 90% of women who had been identified or have been confirmed with cervical cancer should receive treatment. But for like low and middle income countries, where efforts need to be boosted on these 3 key points, preventive options, we need like to make efforts more on HPV vaccination as a critical primary prevention method against cervical cancer. And in the global market, you have 3 types of HPV vaccines. You have the bivalent vaccine, which are targeting 2 types of HPV, 16 and 18. The quadrivalent vaccine, which are targeting 2 other additional vaccines than the bivalent ones, and the nonavalent vaccine, which are targeting 9 HPV genotypes, additionally to the bivalent and quadrivalent ones. So these vaccines are safe and provide strong protection against cervical cancer HPV types. So here I have put some statistics on cervical cancer control strategies in Africa, especially because the HPV infection prevalence is estimated at 21%, with the significant variations from region to region. And here, as you can see, there is 3 programs for prevention, for cervical cancer prevention: the primary, secondary, and tertiary. And in each country, you have informations about if the vaccination program is available, if there is a screening program, national screening program available, or if you have the 3 programs available. How about the HPV vaccination programs in sub-Saharan Africa, for example? So here you have a table which presents for each country the first year of vaccine introduction, idea about the coverage levels for the last dose, or if it's only 1 dose, the coverage associated. And as you can see, for example, here for Senegal, it has been they have started the vaccination on 2018. For Kenya, for example, it's for 2019. And you have an idea here about the covers, which are varying from, for example, for Senegal, from 21 for the first dose to 45% for the first dose in Kenya. But as you can see, there is a big challenges on the coverage levels and the making an effective national vaccination program. And these limitations or barriers are due to, for example, policy implementations, social determinants. A major part is associated, or major cause related to costs, and you can have also limitation due to individual barriers like lack of knowledge, concerns about vaccine safety, for example. So here we have some statistics in Tunisia and Senegal, the countries under study. And as you can see here, you have for the 2 figures, you have the HPV, and you can see on cervical cancer cases, and you can see the 3 most prevalent HPV genotypes are 16, 45, and 18. And they are for Tunisia, the 3 most prevalent HPV genotypes are the same ones, but with different percentage of prevalence. Here, for example, you have an idea about the cervical cancer control in each country, related to screening or vaccination. And as you can see, for Senegal, there is already a HPV vaccine program available, which have been started in 2018. But for Tunisia, it's not available because Tunisia have recently introduced vaccination in April 2025. We will discuss the details later in the coming slides. And this is a report from HPV Information Center, which has not been updated. That's why. And the time we have been done the study, the Tunisian government have not already implemented such a program, vaccination program. So why modeling is useful for decision making? I will make take the example of COVID-19, where the mathematical model and the work related to mathematical model have been exploded in this critical health or critical public health period. As you can see in the figure, modeling can provide you such figures. You can have, for example, an idea about the critical beds occupied monthly here, based on your strategies. For example, the first curve, if you do nothing, so you see the first curve. The second one, if it's case isolation and beds occupied are decreasing. monthly. And if you are implementing a strategy which consists of school closure, case isolation, and general social distancing, the curve associated is the third one, which describes that you are decreasing your beds occupied. So that's why mathematical modeling provides a framework that, of course, given your data, we should combine modeling with data to explain past behavior. And the modeling is not only here for predicting and forecasting future behaviors, but also to evaluate how changes may alter these predictions, because finally we are not predicting the real what will happen in the future. We are only evaluating the future strategies and how the changes can impact the results. In general, I will go briefly here for how we can make a model. So first of all, you need to identify your question before collecting data and formulating your model and making simulations in order to evaluate your strategies. Even you have formulated your model, you need to calibrate it with your data to fit your data. Then if your results are here, you are suggesting you can help decision making. You are not making the decision, you are only helping to make the decision by suggesting the results of the strategies evaluated. It's important to note that in particular, or focusing on cervical cancer prevention, mathematical modeling is a powerful tool because it can permit you to make economic evaluations to determine, for example, whether HPV vaccination provides good value for money or not. I have an idea about the benefits that can appear in a long term, but requiring significant short-term investment. And in general, key policy questions addressed by models are related to, for example, which age groups to vaccinate, how do different vaccine types compare in terms of health and economic impact, and so on. And in general, there is several types of modeling or modeling structure. In general, we have dynamic and static models, which can be used for making the results. So in our study, we have adapted the models validated by the WHO for our local context, and these models are UNIVAC and PRIME, which are static models which consist to following up a cohort of girls using different vaccination scenarios and making the results in terms of health impact and economic outcomes. The health outcomes that have been used in our study are related to cervical cancer incidence, averted compared with your baseline or base case scenario, the cervical cancer mortality associated, and the DALYs averted for each strategy. For PRIME, it stands for a model which is called Papillomavirus Rapid Interface for Modeling and Economics, which is already available and publicly online available. So what about the data sources we have used for making the results? It was we have sourced from a combination of published local and global references, like Globocan for the cervical cancer incidence and mortality, local studies where we have picked cosine estimation in each settings. We have picked from the global other model parameters. So for the first case studies, the case of Tunisia, only just to give you a background of what was happening. At the time, our study was to evaluate the health and economic impact of HPV vaccine introduction in Tunisia. And we have considered various vaccine options. We have to have an idea about the cost associated and the cost effectiveness for each strategy using the two models. And we have used two models, two validated models, in order to present the results for policymakers by using two models in order to have an idea about what can be the differences and similarities between the two. And as I have said before, and after making the results and submitting our paper, it was Tunisia have launched officially the HPV vaccination at schools in April 2025 based on our results. So it was like a tool that have helped decision making in the Tunisian context. So what are the main results of the study? So the first part concerns the health impact associated. So as I have said, we have evaluated four vaccine options: the Chinese vaccine Senegal, the bivalent Cervarix, the quadrivalent, and the nonavalent vaccine. And as you can see in the figure, we have like two point of view. If we are assuming, or two assumptions, if we are assuming no cross protection, which means that each vaccine type is targeted associated, and if we are assuming some vaccines have like a cross protection, which means that even if they are targeting their associated HPV genotypes, they can also have an efficacy, have an effectiveness on other HPV genotypes. And this is the case for example, for the Senegal and the Cervarix. So as you can see here, the health impact, it varies from 60% to 74% for the nonavalent vaccine. When I say 74% is the reduction on burden, or cervical cancer burden, compared to the baseline in Tunisia, which is no vaccination. And we are making the result for the two, using the two models, PRIME and UNIVAC, in order to see similarities and differences. And as you can see, the percentages are at almost the same between the two models. So remember here, or as an important key message, in terms of health impact, the most effective option is the nonavalent vaccine, because it reduces the cancer by 74% compared with no vaccination. But if we come like to economic outcomes, as you can see, each vaccination option, cervical cancer treatments which are produced, and vaccination costs associated. So the total between the two is the economic outcomes associated for each vaccine option. And as you can see here in the figures, why we have four like subplots, because we have the economic costing from a government perspective and from a societal perspective, as we can assume that for each woman who will be treated, there will be like a loss of productivity. So we can see the economic costing from this side also. And as you can see, for the nonavalent vaccine is the option which is the most costly, but the Senegal or the Chinese vaccine is the less costly option. So in terms of health impact, the nonavalent is the most effective, and in terms of the economic outcomes, the Chinese vaccine Senegal is the less costly option. So that's why we need to make a cost effectiveness analysis in order to not only to see the health impact, but also the economic outcomes associated. That's why we have like such a figure, which is like representing the discounted net cost ratio compared with your baseline, which is the gray point here, the gray circle, as a function of your discounted DALYs averted as a measure of effectiveness of the strategy. And as you can see, we have plotted the most cost-effective options in the what we call cost-effectiveness frontier. And we have been ordered the most cost-effective options depending on the costs associated for each strategy. As you can see, the point which is here, the the blue one and the red one is the most cost-effective option comparing with the baseline. But for example, the point which is here, the green one, the non-valent vaccination, in fact, it provides you 70% reduction from the baseline in terms of DALYs, but you see that your costs or the cost associated and your costs will be multiplied by 6.5 comparing to the baseline, your no vaccination. Otherwise, for the 2 points here, the bivalent vaccines, they are providing reduction about 60% reduction compared to the baseline, and your cost ratio will be doubled, will be multiplied by only 2. So you need to make the decision on what is the option you will choose for the vaccination option you will choose. So we have also made some sensitivity analysis to test and validate the models and the robustness of something which is very interesting for a policymaker, which is the probability of being means that given the uncertainty of what I'm saying is true, what is the cost effectiveness of this vaccination options which have been evaluated, willingness to pay threshold, and as not all the countries have a willingness to pay threshold which is general, that's why we are using the GDP per capita for as a willingness to pay threshold for each country. So here, for example, you see that the green curve, which represents the non-valent vaccine. Here, this curve explains that you start to be cost effective at the probability of less than 5% if your willingness to pay exceed what is already assumed. So if your willingness to pay is at $1,100 almost, and you will be cost effective at 100% if you are increasing your willingness to pay at more than or over 2,000. Otherwise, for the bivalent vaccines, which are the two first curves, the yellow and the orange ones, you are cost effective at 100% by only using your GDP per capita at 15%, for example. So it depends on your willingness to pay. If you increase your willingness to pay, you can go for the non-valent vaccine. If not, you can go for the bivalent vaccines. So we are helping for making the decisions and not making the decision. So what have been our recommendations for the Tunisian government? It's that the Chinese vaccine, the Secolin, had a possibility, an ability to reduce the cervical cancer by 60 to 62%, and it's effective and the most cost effective at only 30% GDP per capita. And we have noted an important thing, that our results are sensitive to many factors such as the choice of vaccine, the cross protection assumptions, vaccine price, and the discount rate. Why it's why the vaccine price? Because in Tunisia there is no Gavi support, so they need to purchase the vaccine doses by themselves. That's why they need to have an idea about how is the optimal vaccine price, which will be negotiated with the laboratories, for example. So there have been policy implications, as I have said before, for based for our study. So that's why I reiterate my acknowledgement for the BIMS laboratory and all the team, because their efforts have been there, and their efforts have been used for helping to decision making in in Tunisia. And an important thing here to note is that we have like been also in touch with always in touch with the stakeholders for having their feedbacks. Each time we have like first results or preliminary results, we it had like there we have there were the preliminary results have been shared with the stakeholders to have their feedback. And each time we have like first feedback, we need to refine our model, make the results, and represent the stakeholders which have been on our discussions. So for the Senegalese context, just to make you or to provide you a background of vaccination in Senegal, as I have said before, it has been introduced on 2018, and the setting is different in terms of funding because the national vaccination program has been funded by Gavi, the global alliance for vaccination. So here the objective was totally different than the Tunisian context, because here we are future vaccination strategies compared with what is happening now, what is the baseline, which is the vaccination with the quadrivalent vaccine and by administration 11 to 14 years old. So we have like evaluated like three main strategies or vaccination strategies. It's a group of strategies or vaccination strategies that are suiting. We have not changed the coverage levels which are already existing. We have only evaluated different vaccine options, vaccine products with different dose regimens. For the second group, the moderate increase, we have increased a little bit the coverage levels by evaluating also the vaccine products and the number of doses. And the third group, is an ambitious coverage level, high coverage, aligning with the whole global target by 2030 at 90% coverage, and we have also evaluated for different vaccine options. So in total, we have evaluated 23 strategies compared with the baseline. So what about the main findings of the study? So here in this table, you have for each option the health and economic outcomes associated in terms of cervical cancer cases, deaths, DALYs, vaccination costs, and treatment costs associated. But as I have said before, we need like to have an idea about not only the health impact, but also the economic outcomes. That's why we need to plot the cost effectiveness plane in order to have an idea about the cost effectiveness of the options. So here, just to give you like more clarification about the figure, you have your baseline, which is this point, one, and you have like three form groups or coverage strategies, and each form contains the sub strategies which are associated to each product. That's why we have like 4 colors for the vaccine products and 3 forms representing you are under which main vaccination strategy. If you are in a high coverage level, moderate increase, or current trend or historical patterns. As you can see, I have plotted the cost effectiveness frontier, which is the line containing all the most cost effective options and ordered by costs, by additional costs associated. And as you can see, for example, all the strategies, the green strategies associated to the Senegal vaccine, the Chinese vaccine, saving, because we have here negative values comparing with your base. And here, for example, the point which is here is the vaccination with the non-avalent, it's the non-avalent vaccine with a first dose covered. It's the S19 strategy. And as you can see, you are like exceeding what is suggested as a willingness to pay, because you are here. But it's the most effective option if we can discuss only the health impact. But for example, for the S23, it's cost effective. Even if it's approaching the willingness to pay, you are still cost effective. But you need to make the decision if you want to make savings, or if you want to be cost effective. And we need an important thing to think about: what will be the additional health impact I will gain from moving from the green options to the blue option. So what have been deduced, or before doing that, I will present here the sensitivity analysis for the two most important options. The first one is we have evaluated the probability of being cost effective for the baseline, which is the blue curve, and the strategy which is the most cost saving, which is the orange one. And as you can see, only by comparing these two curves, you can see that what are you doing now, or what is happening now with your current trend and current strategy, you can improve your vaccination program, and you will be making savings. Not only you will improve, but you will be making savings, because you are here cost effective at 100%, at only 5% your GDP per capita. But here, on the right hand side, we have plot the probability of being cost effective for the option which is the most cost effective, which means the S23, this option. And here you can see we have plotted two an interval of willingness to pay. If we are using 30% our GDP per capita, which is represented by the vertical green line, and the other red one, if you are using fully your GDP per capita, 100%. And you can see that your option is at 100% cost effective at a willingness to pay, which exceeds 900, which represents 53% your national GDP per capita. So what are the policy recommendations? We have as I will re-say it again, we are not making the decision, we are helping to make the decision. So we need to provide more or additional information about if the policymakers want to go for the most cost effective option, which is, for example, the non-avalent. As the non-avalent is not government supported, this is one. And the government need to negotiate its price with the laboratories. We are here providing information on what is the optimal price above which you will be cost effective, and you will stay cost effective, or even you will make some cost saving. And for example, here for the strategy, the orange one, the non-avalent vaccine with 2 doses, you will start to be cost effective if your negotiated price is 21 per dose. So you need to make your choice. This is an additional information for policymakers. So as I have said, as a policy recommendation, all the evaluated options have been most of them are cost effective. But like we need to focus on single dose bivalent vaccine strategies, especially those involving the Chinese vaccine with high coverage level. So you are like in front of two options. If you want to administrate 2 doses with a moderate increase, or if you like to only go for only one dose, but with improving the coverage levels at 90%, which is an ambitious target coverage. So in order to compare outcomes between the two studies, we can say that between Tunisia and Senegal, even if the settings are different, because we are like comparing two different settings, economic settings. In Senegal, there is a Gavi support and Tunisia not, but in Senegal, we have also evaluated the strategies above 2030. And this is the year where the Gavi support will or where the government will transition from a Gavi in order to have like a global overview of between the first year of vaccine introduction to 2035 in order to provide information for policymakers what will be their contributions in the future once Gavi support is not here. And as a conclusion, between the two studies, the bivalent vaccines might offer a better cost effectiveness ratio at a lower prices compared with the baseline, even if it's no vaccination or if it's the current vaccination scenario using a different vaccine product. So these vaccines, especially in the context, as I have said, of an ongoing government support and the country's anticipated transition from donor assistance, they advocate for a shift toward bivalent vaccines such as the Secola or bivalent Cervarix. So what is the final key messages we can draw here is for other countries, how can or what can they learn from Senegal, from these two different settings? First of all, a key message on how the use of local data and stakeholder engagement. As I have said before, we will be like always in touch with stakeholders to have their feedbacks and to refine the model approach, and maybe like have more access to data, because as a model we know that the quality of data affects a lot the modeling approach. The second point is the cost effectiveness is context dependent, so it depends on your country. This vaccine option can improve the health situation in your country, but in other settings it cannot. It can be like viewed as it's not like the most cost effective, but you need like to go for other strategies. The third point is the sensitivity analysis, which is a crucial tool because it informs the policymakers that yes, we are proposing this, we are suggesting these options, but don't forget that there is always uncertainty behind our results. That's why we are making sensitivity analysis to like test or evaluate what are the most effective or what are the most influencing parameters, model parameters on results. And the fourth point is the modeling supports real policy process, because for example in Tunisia the modeling have informed the policy makers and helped prepare for HPV vaccination introduction. And in Senegal, it's another thing. It can guide for example, improving the national HPV vaccination program. And the other point, or the final point, is the scalable frameworks, because the approaches used in both countries can be adapted to other low and middle income countries with like contextualization based on their local data. So I would conclude my presentation by reiterate my acknowledgements for all the contributors, institutions, and collaborators which have really support this work. So big thanks for all of these people who have been engaged in this work. Thank you. Thank you for your attention.
Thank you so much, Dr. OUMAIMA, for the insightful session. We now move to the Q&A. So feel free to raise your hand, drop your question in the chat, or unmute to pose your question. Thank you. Purity, go.
I was clapping.
Yeah.
Right.
She was not raising her hand.
We welcome questions now for Dr. OUMAIMA. Thank you for clapping for Dr. OUMAIMA. I think the points she made were very critical, and the processes that she, they went through, she's really taken us through how they did the studies or how they're going about it. Okay. So we have in the chat we have a question. Thank you for the great presentation from Prashant. I might have missed some parts of the presentation due to the intermittent connection. I wanted to get some clarification for the following questions. Dr. OUMAIMA, why did you opt for a static model over a dynamic transmission model, given the change in transmission dynamics of the disease? And then, do I read all the questions, Dr. OUMAIMA, or do you prefer to answer as I read them out?
Okay. Thank you for your questions. So I will start with the first one. What is sorry? Why did you opt for a static model?
Yeah.
I like it's always, I have always like such a question. Why it's not dynamic? Why we are using like such approach and not the dynamic one, the static one, and not the dynamic one? When you are like making cost effectiveness analysis, you are and when you are like in a situation, you need to, because for example your country is approaching the introduction and informations about what are the cost effectiveness, or what are the options that are the most cost effective. The static models is commonly used for such analysis, or cost effectiveness analysis. You can even use dynamic one, but the most approaches, or the most commonly used, are static models for carrying out cost effectiveness analysis. I will move to the second question. Did you explore vaccine strategies that included the routine campaigns, school-based? Okay. I will answer for the two settings, for Tunisia and Senegal. For Tunisia, we have like discussed with some stakeholders from the ministry. Tunisia, like the vaccine is approaching to be compulsory, because it will be administered to girls which are at the final year of primary school. So it's like we have like targeted this delivery administration, because we will target a large number of girls, and it can be feasible for Tunisia, because we have like a statistics, and we have an idea about what will be the coverage, and the coverage is approaching like 85%. For Senegal, we have not considered the delivery strategy, or the type of delivery strategy, but for Senegal, they are like administration the vaccine outreach, and there is like also a school-based campaign, which is not like routine. The third question: did your vaccination costs include Gavi support? I have mentioned earlier. For Tunisia, they are not eligible to Gavi support. So that's why our vaccination cost is from a government perspective. What is the contribution of government, and what are the costs associated for purchasing the vaccine doses? As Senegal is eligible for Gavi support, and we have like we have made the study on from the first year of introduction, which is 2019, to the year 2035 for having an idea, because by 2030 the country will transition from it. This important point be considered in our cost effectiveness analysis. The last one: how did you approach the policy makers with your results? A good question. I've been on a workshop on Cameroon and I've received the same question. How did you approach the policymakers? You see, when you are like working on when it's a teamwork, englobing like physicians, biologists, persons that are like infecting or impacting the decisions in your country, you'll be always in touch with policymakers, because I think it's this question. I think we have been like we have been lucky, because we have been like well supported. But it's a good point. It's a really good question, because always the problem is how we can approach the policymakers. You can, for example, it has been important for our study because for the data collection, for having the feedbacks, for refining the models, then remaking the results. So thank you for your question. Okay, we move on to the next questions. Nani?
Yes, please. I think Osindi Boniface was one. It's right after the ones that you just covered.
Curious, given that UNIVAC and PRIME are both static cohort models, how did you validate the model outputs against real-world data or proxy benchmarks? And did you consider using dynamic transmission models to better capture head effects and time-dependent changes in HPV prevalence? Okay, thank you for your question. As I have said, when you are like presenting your results for policymakers, the first point they are discussing is why your model is like how can or at which point your model is fitting the real world. And when you are saying that you are using two models that have been already validated by the WHO, by the World Health Organization, like they can be more confident on your result. It can be you can develop your own model, your dynamic model, which can capture another herd effects. And it has been done for Tunisia for HPV screening using a dynamic model, an agent-based model. And this model was adapted, which is the model is called HPV SIM text. But as I have said before, if you are saying that your models have been like validated by a group which is related to global, like sources or global institutions, your results and the policymakers will be like more confident on what you are seeing and what you are presenting as a result.
Okay, maybe I can ask my question.
Sure, go ahead.
All right. My question is, the overall presentation is talking about the cost-effective analysis of HPV. Then, did you consider the how effective is the vaccine? Is the vaccine very effective? Is there any way somebody has been vaccinated but later the person has been diagnosed to be contracted with the HPV. So how effective is the vaccine? Because that is very, very important.
Okay, as I have said, for Tunisia, they are like we have made two separate cost effectiveness on HPV screening and vaccination, and another study which has been presented today concerning only vaccination, and the effectiveness of the vaccination strategies has been like considered or measured in terms of cervical cancer. So like we assume that the effectiveness is only on cervical cancer. And what is like the differences between the vaccine options, or how we have measured the effectiveness of each vaccine product? We have been like based on clinical trials which are already like public available for each vaccine on cervical cancer, because I need like to know that for each vaccine there is an effectiveness on genital warts before you develop, it's your precancer stage, and there is like another effectiveness on cervical cancer itself. And we have used the HPV genotype distributions because each vaccine is targeting different genotypes, and different genotypes are leading to by a different percentage or by different probability to cervical cancer.
We have some unanswered questions on the chat. Florence Wakesho, can you see the question by Florence? And then there's one other.
The last one?
No, the Florence sent one at 12:48 p.m. So just up, just scroll.
Do freight charges and in-country distribution channels of these commodities affect the costing? I will, to answer to this question, I will like walking you on what is or how the estimation or the costing estimates have been done. So for the vaccination costs, we have like it's for the UNIVAC model. We have already like a part which is like detailing your estimation costs associated to each vaccine option. You have first of all the vaccine price per dose, then you have the delivery. It's like all the related indirect related costs to purchasing the vaccines are represented by a percentage, and it differs from country to country, because it's like, for example, your delivery strategy in percentage would be such a value, for the other country it's another value. We have been also included not only the delivery but also the prices of cylinders, the safety box, the cold chain, and all the related, the insurance, all the related costs. And for example, for Tunisia and Senegal, you have like related costs which will be like having the big part only for the first years, because maybe after this cost will not be there, and it affects your results.
We have another one by Kudet as well, and then I think we will wrap it up with Prashant's question. Oh, there's Patricia's question and then Prashant.
I'm curious to know which
yeah, quickly.
Okay, good. I'm curious to know which parameters or criteria were used to determine the willingness to pay threshold for the HPV vaccination in your analysis. Okay, thank you for your question. It was, as I have said before, it's a key point on doing cost effectiveness. What is the willingness to pay threshold like determined or estimated for each country? And as we have no idea about that, and several studies or global studies used to like making or testing the cost effectiveness of different options based on the GDP per capita, the ground domestic product for each country, and you have like an interval. The WHO suggestion is you are cost effective if you're by considering, for example, you can have. That's why for our analysis for the sensitivity analysis, you have like a percentage of GDP, and with which probability will be cost effective depending on if you are like using your full GDP per capita, if you are at 100%, or if you are less. So such plot or such result is very important, because we don't have an idea about what is a determined willingness to pay. So that's why we need like to test over an interval of willingness to pay, from 0% to fully your willingness to pay, which is like tied with your GDP.
Yeah, if you could quickly address Patricia's and then Prashant's, and then we end the session.
Patricia, thank you. That's an excellent. Since the launch in April 2025, how has been the uptake of the vaccination? Good question, because it's we have like after the official launching or the official introduction, the uptake of the vaccine it's not succeeding yet, but we are trying to push this rollout to improve it by the time, and we are like making some sensitivity to people in order, because it's always like a problem of vaccine acceptability, and we are like having some scoping groups to have an idea about what are the feedbacks, to have an idea about if the national program is improving or not. So until now, it's not like what we have been expected about the launch, the uptake of the vaccination. I have a last question here. Prashant, sorry, one more question. If time allows, did you think of adding the cost of treating adverse effects following immunization into the cost of vaccination? In fact, in our study, we have not considered these adverse effects, because the problem is how you can measure the adverse effects in order to measure the cost associated to this consideration. But I don't think that the results will be like affected very, very. It will be not very affected if we consider this point additionally.
Amazing. Thank you so much, Dr. OUMAIMA, and that brings us to the end of our session. Thank you, Dr. OUMAIMA, again, and everyone for your time and engagement. I'll see you next time when we have another session. So keep posted on. We will keep you posted on this in our socials and emails, and also our website regarding the next seminar. Thank you so much.
Thank you all. Thank you. I reiterate my my acknowledgement for all of you of being present today, and for thank you for your time.
Thank you.
See you next time, maybe.